Oh my gosh, sorry guys. I was there chatting away and didn't realize I hadn't turned back on my mic. So just to go back briefly, respiratory distress is increased workup breathing, and that usually happens when you have insufficient oxygen. You're not getting in enough oxygen and you're not getting out enough carbon dioxide. So it could be one or the other, or it could be both. Now, respiratory failure, it's clearly defined. You know if somebody's in respiratory failure. But you also need to determine the degree of respiratory failure, and that can only be determined by your blood gas. So in a newborn, if it's about a clinical and in terms of a laboratory determination. So in a newborn, if the partial pressure of oxygen is less than 60 and the arterial PaCO, partial pressure of carbon dioxide, is greater than 50, then we consider that this child or this newborn is in respiratory failure. And as it worsens, then we know that the baby might need ventilation or might need another form of support other than just the ventilator. What else we need to put in place to try and save this baby? Now for a newborn baby, the normal respiratory rate is 40 to 60. And for babies, they don't breathe like adults. They tend to pause in between their breathing. You notice them when you guys go on the nurse, they might breathe fast, then they slow down, might even stop, and then they start breathing fast again. That is normal. If it doesn't go beyond 5 seconds, then we're not concerned. And then it mainly occurs when they're asleep, but it can occur when they're awake. And there's usually no signs of distress, intercostal or subcostal retractions, no grunting. But in premature babies, especially the fine ones that don't have any fat, don't have a gain in weight, they just have the skin and the bone, they don't have a lot of fat on them. You can have intercostal and subcostal retractions, but that doesn't necessarily mean that they're in respiratory failure. It's just that as they put on weight, you will notice the movement of the lungs and the ribs in between. They just need to put on some fat. So it depends on the size of the baby and how much fat they have on them. The heart rate is also very important, because the heart rate of a newborn is between 120 and 160, but if it's a post-dated baby, they can go down as low as 100 or even more. We're not concerned. Once you stimulate them and the heart rate goes up, that is normal as well. So the older the baby, because you do get babies 2 weeks past the time they should deliver, so their respiratory rate might be a little low, and we're not concerned about that. So it all depends on the gestational age of the baby. Now for today, any questions I need to ask? Any questions so far? No? Okay. I guess you would send up a chat if you had questions. So in terms of what we're going to look at today, there are pulmonary and extrapulmonary causes of respiratory distress. And we're going to deal with the pulmonary causes today in the interest of time. We're going to look at certain areas. We're going to look at respiratory distress syndrome, which is mainly seen in our preterm infants, pulmonary hemorrhage, and if you have a pneumothorax or what we call an air leak. Then the other group, which can occur in both preterm, late preterm, and late preterms are babies that are greater than 34 weeks but less than 38 weeks, go to 37 plus 6 days, 37 weeks plus 6 days. These are a special group of babies, the late preterms, that have other problems, but you won't see, it won't be as bad as a preterm, but they're still preterm babies, so they can have problems that you need to be aware of, and it's a special group that you really need to consider, that you have to be careful with them. They're not quite preterm, but they can have problems. We're going to look at meconium aspiration syndrome, pneumonia. Again, they have problems with pneumothorax. Any baby can have a pneumothorax. Then we have less common causes like the pulmonary congenital malformations that can result in respiratory distress in a newborn. You always have to keep in mind that babies can breathe fast for various reasons. It might not necessarily relate to the lungs. And you must always think of that when a baby comes to you breathing fast when you work with a baby. Babies who have had problems at birth can have, if they have hypoxic ischemic encephalopathy or an injury that causes them to have problem breathing, These other disorders are unusual, myasthenia gravis or muscular dystrophies, but you do see them, and it's just that the nerves are not developed enough for them to breathe fast in terms of the muscles. The other area is, and the one I just wanted to remember, which is common, is choanal atresia. And how would these babies present? Just briefly, somebody has ever seen a baby with choanal atresia? And what does it mean? No volunteers? I like the interaction in people. Come on, tell me, choanal atresia, how do you pick up a baby has choanal atresia? Do I have to call on somebody? I see something going there, hypoxia. So how do they classically present? All right, because so some persons have it. So a baby with choanal atresia will look very blue. The baby is just blue. And what causes, just to tell you what caused it in the interest of time, is that the baby's choanal atresia mean that the passageway, the nose is not open. It can be blocked by bone, it can be blocked by cartilage. Babies are not mouth breathers. They breathe through the nose. So if anything obstruct the nose, they don't know that they need to open their mouth to breathe. They're not at that level. So they find that, in terms of their development, so they tend to breathe through their nose. So when you see a baby that is blue, and then if the baby gets agitated and they become pink, that's a classic example of choanal atresia. That's how they present. If you have any baby that is blue and the baby starts crying for whatever reason and becomes pink, that should be the first reason you think of why this baby is having problems with breathing and becoming blue and hypoxic. So that's how choanal atresia usually presents, and you shouldn't miss that. If you try passing a tube through the nose, you notice it's not passing, that's a ENT emergency. That baby needs to be transferred to the surgeons. So that's the one condition I want you not to miss in any baby that's blue and suddenly turns pink when they start crying. There are other abnormalities. Abdominal distension is a classic one that you should also take into consideration. When a baby is distended, especially severely distended, it's going to push on the diaphragm. So when they try to breathe, they can't get the expansion that they need. So that baby would need to pass an NG tube and to empty that stomach to help them with their breathing. It occurs in some babies if they have necrotizing enterocolitis, anything in the abdomen, a lot of fluid, it's going to affect their breathing. And so you have to get that abdomen down as much as possible to try and help them with the breathing. And then there are other things if they're in heart failure, pulmonary, if they have pulmonary edema. But just to go to our topic, and that's just some basic things that you need to remember. Not every baby that breathes fast is due to the lungs. Look for other, if it's not adding up, look for other things. So how do these babies present? They have tachypnea, tachycardia. We told you what is the norm for the babies. Intercostal, subcostal, and tracheal tugging. They can become cyanose, grunting, or they could just go apneic, in which they just stop breathing altogether. And then it will be shown clinically where they have the skin start looking mottled with poor perfusion, causing not enough oxygen. And when they reach a stage of having seizures, gasping respiration, and those babies need to be on a ventilator, they need help. So the general management, you always have to remember that you always start with the ABC. Airway, breathing, circulation, and to give oxygen. That's how you approach any baby that is having respiratory. Just make sure the airway is clear, there's no secretion, see how they're breathing, and give them the oxygen. ABC at every level of your exam. Anybody that comes to you in distress, you must do your ABC, and remember your blood pressure as a part of it, the oxygen, clear the airways, position the head, especially in a newborn. The head must be slightly back because it can obstruct them from breathing. And of course, you must do your arterial blood gas to see the severity of the problem. And those that require intubation, you intubate, and then you find out what is causing the babies to be distressed. So we're going to start with our first topic, which is respiratory distress syndrome. So this is basically due to surfactant deficiency. It's very common worldwide. Any premature baby is at risk for this, and it's more prominent in males. It's more common in babies less than 28 weeks, and then a third occurs in babies between 28 and 34 weeks. And it's unusual in babies greater than 34 weeks. This is now the late preterm babies. The ones that tend to get it mainly at term is babies whose mothers have maternal diabetes. And of course, if a baby has perinatal asphyxia. But why is a diabetic mother prone to have RDS? What causes it? What we cause an infant of a diabetic mother to present with respiratory distress or respiratory distress syndrome? Is that Bilal? I see that.
Yeah, is the mother
Yes.
diabetic before pregnancy
At birth.
or at birth? As in, so when that
Once
affect,
they're diabetic, whether it's pre-gestational or gestational, they're both at risk.
can affect organ development? Can't it?
Repeat that?
Organogenesis? Can it affect organogenesis? Diabetes?
No. What else? What does diabetes cause in a newborn? What happens in a newborn?
Will they get huge?
They tend to be big babies. But what
Yeah.
are the elements that you have? What the sugar is high, and what counteracts that?
Insulin, hyperinsulin,
Yeah,
hyperinsulin.
hyperinsulinemia.
Yeah.
Yeah, and what does insulin affect that can prevent the lungs in terms of the surfactant from producing?
So it inhibits the corticosteroids
Yes, the
that help
steroids.
with the maturation.
Exactly. So that is why they have RDS, because it inhibits cortisol, and that is needed for maturation of the type 2 pneumocytes and the production of surfactants. So that's why a baby with IDM can present with respiratory distress syndrome if the mother is poorly controlled. So you have to always keep that in mind as well. That's a group that can get it. For perinatal asphyxia with severe hypoxia, it actually destroys the type 2 pneumocytes. And so you don't get surfactant production in severe hypoxic insult. So that's why they're also at risk. So we're going to go through this quickly in terms of what happens for a prem baby. So in addition to the surfactant deficiency, what is this? In addition to the surfactant deficiency, what happens, a major thing in premature baby is that it's not just the surfactant that causes them to have the distress. What happens is that the lung, when babies breathe, when they're term, and as adults, when we breathe, our lungs expand and our chest goes out. So more air is able to come in, more oxygen. For premature babies, because of underdevelopment of the cartilage and the bone, when they breathe, the chest actually goes in. So they have more problems with breathing. And that, in addition to surfactant deficiency, they have poor structural lung development. So that worsens their breathing. And that's why their RDS, depending on how premature they are, can be worse. The younger they are, they have a mixture of both surfactant deficiency and nothing to support their chest so that the lungs can expand properly. They always tends to collapse. So that's why they need help sometimes to put them on CPAP to help to keep the structure open. So when they have the RDS, they can have hypoxia, hypercapnia, meaning they can't get out the CO2, they can't breathe well, can't get in the oxygen, which is going to cause the respiratory distress, and eventually leads to what we call a proteinous exudate, because everything is collapsing. A lot of fluids start to collect in the lungs, and that's why they used to call it hyaline membrane disease. Now it's called respiratory distress syndrome. So most of these babies, when they're delivered, within the first couple of hours, the most 6 hours, you might think these babies are fine, especially the ones at 26 to 27 weeks, and suddenly, when they no longer have the effect of the mother that has gotten rid of all of the excess fluid in the lungs, who has been helping them out, they start to get worse. And that's when you have to notice you need to put them on CPAP, you might have to give them surfactant, and some might reach a stage that you definitely have to put them on the ventilator. If the baby is cold, it's going to worsen their condition in terms of instability, thermal instability, and also if they have an infection, that makes it harder for them to fight anything. So some babies do require septic workup. But if the baby is a iatrogenic prem, these are babies that are delivered because of maternal causes. Mother has hypertension, mother has cardiac failure, no indication that mother had an infection. These babies do not or should not be put on antibiotics. There's no reason to put them on antibiotics. They were delivered because of the mom, and you deal with the underlying problem, which is RDS, because they were delivered too early. If the mother had a UTI or had a fever, then that's different. That's a baby that definitely needs a septic workup and should be put on antibiotics. Usually most babies, if we're lucky, the older ones tend to get better within 72 hours, but we don't find that with our very premature babies less than 28 weeks, or even up to our 30-weeker that might need more help in terms of a longer time. And this is sometimes after treatment. So in terms of the x-ray, this is a classic x-ray of a baby with RDS. And is that Cabrina? Could you interpret that x-ray? Just look at the picture and tell me what you see there.
Hi, morning, doc. So from this X-ray, I noticed that the ribs are horizontal. I can note that there are tubings on this
The
patient.
last thing you said,
Tubings.
what is tubings?
I'm not entirely sure what this is on the patient, but yeah. But I can see the radio opaque line on whatever tube this is. Yeah, I noticed there's a air on the left, under the left diaphragm, most likely because of the stomach.
Yeah, that's the stomach there.
Um, I'm not noticing any discrepancies with the soft tissue, nor any fractures to the bone.
All right, so you have a general idea. So what happens when the baby has surfactant is that you will see the alveoli would be inflated. So you actually see the lungs itself. This baby has severe RDS. So everything is collapsed and full of fluid alveoli. So that's why you're getting the white out appearance that you see there. So everything is white out because there's very little air going into the alveoli. But what you mentioned, these things we call the air bronchograms, they don't need surfactant to stay open. So you see in these opaque areas, you're seeing these darker areas, not opaque. These are what we call air bronchograms, which are classic of RDS. You might see a small one there, that the air bronchograms are trying to get to the alveoli, but they're all collapsed. And so you have the white out appearance, and then in addition to that, you see these translucent too. Well, we will call these are just the air bronchograms with the air going down. Kevin, go ahead.
Excuse me, Doc. Could you use the pointer when you're speaking?
I am. You're not seeing it?
No, Doc.
Let me try again. I thought you were. You're still not seeing my hand pointing to the areas?
No, Doc.
I thought the pointer was the one with the hand. Am I missing something again? Are you seeing that now?
No, Doc.
You're not seeing anything?
Doc, perhaps you can use the pen and draw instead.
Just try. It's the draw I was using, but it's not working either. That's why I'd gone to the draw thinking that would help.
Oh.
But I was using the one with the hand to see, but it's not showing either. Oh, I see the pen mark here, but Not sure where the hand is. Are you not seeing the pointer either? I'm using it again.
Yes, I can see that blue marking.
Yeah, that was with the pen, but you're not seeing the hand?
No, doc. I don't think the hand is a pointer, to be honest.
I'm not seeing anything else to use as a pointer. That's the problem. I just see the pen.
But wherever you're talking about on
Let me
the
try use the
diagram,
pencil to help again. It's just going to mark up the thing. But I'm going to put the pen where the air bronchograms are and hoping that it will show. You see where that line is? That small blue dot?
yes, doc.
Are you seeing it? If you look at that area, you're going to see a translucent line running right down. I'm going to put another dot there just to show you those little areas where you see that translucent area. That is called an air bronchogram. Is everybody noticing that?
Yes, Doc, I see it.
Okay, so that's where the air bronchograms are, and it's based off a radio opaque. You see, like everything else looks white out compared to those areas. So that's what you look for if you get to interpret these X-rays. Look for those air bronchograms, which is clearly in keeping with RDS. So the treatment is usually for babies, you should give surfactant, especially premature ones, you give surfactant and you offer respiratory support. Some babies might just require CPAP, which is continuous positive airway pressure, in which you give that. It can be just to keep it helps to keep the chest open. It helps to help with the alveoli, to keep it, not the alveoli, but it helps to keep the air bronchograms open, keep the pressures in the lungs to a level that the babies can breathe until they're able to do it on their own. When they reach a ventilator now, then you're basically doing everything for them because they can no longer breathe on their own. So the severity depends on which one they need. But we always try them on the CPAP before we actually put a tube down to ventilate. You have to make sure that the temperature is okay and that you have to also be careful with the oxygen saturation. What's the normal oxygen saturation that we should have for a baby? Especially not a baby, a premature baby, where you want to keep the oxygen saturation at. So when you put the probe, the oxygen sat monitor on the finger, what is the sat you want? You can, on our babies, to put it on the hand. Anybody, as I say, ABC, always your oxygen sat. What's the level, what range you want the oxygen sat to be in a premature baby? Definitely not greater than 95%. So between 90 to 95, some persons say around 92. The reason for that is that high oxygen is never ever good for a premature baby. High oxygen is actually detrimental to a premature baby. It damages the eyes. It's a major cause of retinopathy of prematurity. And oxygen also has effect. Too much oxygen at this age also has an effect on the brain and even the lungs itself. Because you have to remember, these are babies who are in an environment in the uterus where their saturation was 40%. Because mother was doing everything. They were ready to be born. Now they're suddenly exposed to this high level of oxygen, which the body has to now adjust to, and can damage other organs as a result because they needed to have stayed in there till the organs were mature enough to deal with what is even 21%, and now we're giving them 50%. How much oxygen? So it is detrimental. So it's very important that you keep your saturation between 90 to 95, 92 to protect the other organs who wasn't quite ready for all of this oxygen level. So that's because we used to have high cases of retinopathy of prematurity and blindness way back until we realized what was causing it. That the doctor, we were causing it unknowingly, damaging the baby's eyes because of the high oxygen and might be having long-term effects on their brain. Nutrition is also important. As I mentioned, they need to put on weight so that they can start breathing better on their own, so they can start building, get themselves stronger, the lungs stronger. So ideally, premature babies that can't feed on their own should start what we call parenteral nutrition. in the veins. It's broken down to the minor, to the basic amino acid, fats, glucose, and then we start oral feeding as soon as possible, preferably with breast milk, because the gut is also developing and not quite ready for anything other than breast milk. Giving them formula, it might be too harsh on the stomach, although sometimes we are forced to, but you need to get them to put on weight as quickly as possible. Most of our babies at university suffer from severe malnutrition because of TPN not being readily available, and the outcome is not good because of that. We really need to get nutrition as priority, and it happens in many hospitals that don't have TPN. A lot of the first world countries is not a problem, but for us in the Caribbean, feeding our babies until they're able to feed enough orally is a problem. And of course, the kidneys, they tend to lose a lot of fluids from the kidneys, so you have to make sure that you're giving enough fluids to counteract the immaturity of the kidneys that they have. So it's something we keep an eye on, the renal function. As I mentioned before, you only give antibiotics if you need to. Any baby that is ventilated, the other thing you watch is the hemoglobin, because the problem they have that can occur is that we tend to take a lot of blood from premature babies. We're constantly doing blood gas, we're constantly checking the renal function, we're constantly checking for infections, is that the hemoglobin can drop quickly. In addition, they are at risk of having what we call intraventricular hemorrhage, which is not a topic we're going to discuss today. But with premature babies, the vessels in the brain is very weak. So anything that stresses them out, if they have the blood pressure goes up, if they're stressed for whatever reason, they can have a spontaneous bleed in the brain. So the hemoglobin can drop significantly. So if the hemoglobin drops to less than 10, and they're on the ventilator, you must transfuse, because if it's the oxygen, remember the hemoglobin carries the oxygen. So if they're not getting enough oxygen, they're going to show signs they're not breathing well, they're starting to have more problems. You have to be increasing the settings on the vent, which you don't want to, give them more oxygen. So any baby that is ventilated must have a hemoglobin greater than 10 on the ventilator. The complications of RDS is it can have a pneumothorax. Remember that we are now ventilating these babies. If our pressures are too high, if just having the RDS alone puts them at risk, they can have a leak in terms of a spontaneous alveoli that suddenly pops, or several of them pop, and you have a pneumothorax, which requires putting in a tube to drain the air that is no longer in the lungs but outside of the lungs. If you don't know how to intubate, it's a problem. It can damage the upper airways. You know, introducing foreign things into the baby, the ET tube, the NG tube, IV lines, so they're at risk of infection. It can have problems with the heart, because if the lungs is having problem in high pressures, not able to inflate, it can have an effect on the patent ductus arteriosus, or the cardiac function, because it's fighting against the high pressures in terms of the lungs. And of course, the long-term effect can have chronic lung disease, and this is defined as any baby, especially those less than 28 weeks, who with oxygen support or cardiac, or in terms of having to be on some form of support, whether it's CPAP or the ventilator for greater than 28 days, they're considered to have chronic lung disease. And I mentioned before in terms of retinopathy of prematurity, and of course, intraventricular hemorrhage, which is a common complication of ventilated babies, and poor nutrition. So these are some of the complications you have to look for or expect in babies who have RDS. In terms of pulmonary hemorrhage, pulmonary hemorrhage is very, very bad in any baby, because if you already have RDS and then you bleed in the lungs, then the chance of survival is very small. Most babies with pulmonary hemorrhage do not survive. And what mainly causes in terms of RDS is that you notice that a baby is having problems breathing. And I have it there, I shouldn't have put up the slide, but I should. So let me start. What do you think could cause pulmonary hemorrhage? It's on the other slide, but why do you think a baby would bleed in the lungs? we have it there, if you give them too much volume in terms of the fluid, it can pop the lungs. It's usually bleeding from the capillary levels. Why after, but it's associated also in our babies, it's mainly associated with giving surfactant. Why do you think giving surfactant could cause pulmonary hemorrhage?
Excuse me, doc, would giving surfactant increase the pulmonary pressures and cause pulmonary hypertension, which would ultimately affect the capillaries?
You're sort of close, but let me correct you a little. What happens is that when you give surfactant, remember that the baby with hypoxia, the vessels are constricted. When a term baby is just delivered, they're usually blue. When they take their first breath, the capillaries slowly open and then they start getting pink. They take them up to 10 minutes to get pink as the vessels suddenly open up and the pulmonary constriction improves. When you give surfactant suddenly to a baby, there's a rapid increase in terms of the vessel constriction. It opens up faster than natural breathing. So when that happens, the capillaries can suddenly pop with a sudden increase, and that's what causes a pulmonary hemorrhage. Because they're not breathing normally on their own, we are giving them surfactant, which causes suddenly, as you get more oxygen, the oxygen suddenly starts to improve as the alveoli opens up, and then the capillaries respond by opening up quickly, and that's what causes the risk of pulmonary hemorrhage. So it is related to the capillary vessels, but it's how quickly they open. Giving surfactant causes them to open quicker than they would normal if they were breathing on their own, and that can lead to pulmonary hemorrhage. And usually the babies are picked up when they suddenly look pale, but mainly if there's any blood coming up the ET tube, that is pulmonary hemorrhage. And it can be a pink frothy fluid or just frank blood that tends to come up, and that's a sign of pulmonary hemorrhage. As I said, if the baby was on CPAP, you need to intubate. And if they're intubated, then there are other things you need to put in place. Of course, the treatment, you have to try and get rid of the blood so that as much as possible, but suction is not going to help, because where the bleed, it can help with the upper airway, but the bleeding is in the lungs. So one of the things that you have to do in order to help with pulmonary hemorrhage, have you done the ventilator courses yet to understand what PEEP is? Peak and expiratory pressure? You understand what that term means? Nobody has been to ventilation, been to the anesthetic course? Yes, no?
Yes, Doc.
So you know what PEEP is?
I suppose so.
So the peak and expiratory pressure is basically what, in terms of what we use to keep the lower alveoli open. And what that does is that what we have to do in a baby with pulmonary hemorrhage is that we have to try and compress the vessels. And the way to compress the vessels is to increase the PEEP so that the alveoli pushes against the blood vessels and reduce the amount of bleeding that is occurring. So that's what it would help in terms of reducing the amount of bleeding that's occurring in the alveoli. So the babies must be ventilated. If the baby was on a PEEP of 5, then increase it to 6 to try and compress the vessels. Strange enough, blood destroys alveoli, it destroys surfactant. It makes the surfactant inactive, and the same thing that might have caused it, we might have to give another dose of surfactant to try and keep the alveoli open, because they're going to start collapsing without surfactant. And of course, as I said, the prognosis is usually very poor. Most babies die because by the time we can intervene, there's so much blood in the lungs. They're not only dying from hypoxia, they're also dying because now they are so anemic and they have problems breathing. So the prognosis is usually poor for these babies, but we try and get them blood, we try and get them the surfactant, and we try to put the PEEP up as high as possible to try and save them. And of course, you cannot manage a baby with pulmonary hemorrhage unless they're intubated, because you need to get that PEEP, and the only way to get that PEEP up is to get the ET tube down so you can put as much pressure on the alveoli as possible. And they can't breathe on their own at this stage because the lungs is full of blood and other things. So that's how you manage your pulmonary hemorrhage. All right, the other one that we're going to do in terms of is our meconium aspiration syndrome. So meconium aspiration, any questions before we move on? All right, no good. So meconium aspiration syndrome is different from just having meconium stain liquor. We have quite a few percent of babies who are delivered through meconium stain liquor, but only around 4% actually develop meconium aspiration syndrome. So you have babies that always pass meconium sometimes before they are born in the amniotic fluid. Some if they're distressed during the time of delivery, but not all develop meconium aspiration syndrome, in which they swallow enough in the lungs to cause problems. It's seen in babies who are small for gestational age that show you that they were distressed from in utero. Post-mature babies, it's normal after 40 weeks to pass stool because now they just want to come out. The placenta not working anymore. They're doing the normal thing. And if there are other complications, cord around the neck, anything else will cause a baby. If they're hypoxic, they will pass stool in utero. Premature babies less than 34 weeks should not be passed in, especially the younger ones, stool in the amniotic fluid. The bowel is not developed enough. So any baby that passes, a premature baby that is delivered through amniotic fluid that looks like meconium, think of listeria. It can look like meconium in terms of the color, but no baby, if a 28-weeker is passing through meconium stain fluid, that is not meconium. No baby at that stage has bowel developed enough, less than 34 weeks, to be passing meconium stain. So you look for an infection in that baby. And the one most commonly I saw that looks like that is listeria. So just to give you an idea, once in the old time days, they say you had to pass a lot of meconium to have meconium aspiration syndrome, that the baby swallows enough meconium. Now, there are 3 causes of meconium aspiration syndrome. You can have the obstruction based off the amount of meconium that you swallow, but there's also meconium causes chemical inflammation. If you swallow a small amount, it inflames the alveoli and the lungs and the other areas, so you can have that response, and it also inactivates the surfactant. So it works in 3 ways to cause meconium aspiration syndrome and the severity of it. The one that you have to remember is that we have air trapping, and air trapping can occur in 2 ways. You have complete obstruction where it just blocks off everything, and then you have the ball valve effect. What is the ball valve effect? Which is the one that is even more dangerous. Ashley, I seen your name there, sorry. What is the ball valve effect? Any idea, or any of your colleagues? No volunteer?
Can you repeat the question, please?
The ball valve effect that occurs in the lungs with meconium aspiration. Have you ever heard that term?
No.
Anyone has ever heard that term?
Is it when there's partial obstruction due to meconium and that causes like inflow of air during inspiration, but it's hard to expel?
Exactly. That is the ball valve. So when the baby breathes in, air goes in, but when they're breathing out, it's collapsed. So you keep on getting air in the alveoli, but you can't get it out. So it reaches a point where they can suddenly have a pneumothorax. It is so much air in there, there's spontaneous air leaks, and that's what is the ball valve effect that can cause a pneumothorax in a baby with meconium aspiration syndrome. And then they can have the complete atelectasis where everything just shut off. You have inactivation of surfactant, you have the whole chemical inflammation, and that can cause atelectasis. They can have what we call shunting, because the areas that are blocked off, no blood is going there, so it's going to other areas, and there's no oxygenation in that. So it basically it can lead to air leak, as we mentioned, hypoxemia, you can't get out your CO2, respiratory failure. And there's another thing we're going to discuss is persistent pulmonary hypertension in a short while, which is usually the causes the death of a lot of babies with meconium aspiration syndrome. We mentioned this when these babies are delivered, most of them show signs of post-maturity. And they also look wrinkled, quite wrinkled. You can spot them from a mile. Once you enter the nursery, you know this is a MAS baby. They're usually older, sometimes even the younger ones, but they have been suffering this from placental insufficiency, whatever reason. You find that the skin is wrinkled and thick. You notice the nails are long. That tells you it's a post-mature baby. They're heavily stained, and the long nails, the thick skin. And the major thing you notice is the chest is massive. Compared to other babies on the nursery, you see this baby with this hyperinflated chest, and this is from the ball valve effect with the air trapping. So you notice a big-chested baby that looks old and mature. That's classical picture you see in a baby with meconium aspiration syndrome. So babies usually are depressed at birth, depending on the severity, or some comes out kicking and screaming, but then eventually they develop respiratory distress. And of course, the hyperinflation is a signal that this baby has meconium aspiration syndrome. Just to go to the picture, since I can't get the thing to work, I'm not sure why it's giving me a hard time. Are you still not seeing it now? Can't say anything. All right. So what usually happens is that I'm going to use the marker to show you again, just to mark it up and down, because you see in the drawing, is that when you look on a picture with meconium aspiration syndrome, I want you to look at that area. You see in the mark, the areas I'm pointing to?
Yes, doc.
You notice where the liver is supposed to be at, that diaphragm is supposed to be at the same level. So actually it's supposed to be higher because of the liver. In a baby who's hyperinflated, you notice that it's almost at the same level of the other diaphragm, and it's being put, this is an air leak that you actually see in there. You see that pocket of air that is there? That's what you see in the picture. In the other one with the dot, this is an air leak as well. And it's actually tracking along the side. So you see pockets of excessive hyperinflation. Those are areas of air leak that occur because of the ball valve effect. In this area, which is I put in the other mark, is where you have areas of complete obstruction, where you just have the alveoli collapse, and so you see now whiteout. So compared to the picture of RDS, where everything is whiteout, in meconium aspiration syndrome, you're going to see areas of hyperinflation, the diaphragm pushed down, and areas of atelectasis. And that's a classic picture of meconium aspiration syndrome. Everybody understands that?
Doc, can you please repeat the three signs that you see on radiograph?
So you're going to see where the dots are, the one at the upper, okay, I'm gonna get myself lost now, the left and the right. You see at the upper left where you see that pocket, where you see that little pocket where the blue dot is?
Yes, Doc.
You see like a pocket of this pocket of air. And you go at the bottom where the liver is, you see that, also see that area that is mainly dark, that is air. You're not supposed to see that. So, and in addition to that, where the third dot I put, which is here, you're going to see areas where you're going to have hyperinflation and areas where you're going to have atelectasis, which is whiteout. So you get a mixture of hyperinflation and atelectasis, which is in keeping with meconium aspiration syndrome. So it's not like in RDS where you get a total whiteout, because remember the ball valve effect is going to cause it to have areas where you're going to have small air leaks. So you have to remember that when you get these x-rays that it's going to be different. You understand now, or you?
Yes,
what you're so
I understand now. Thank you, Doc.
Yes, we got it faster. So complications, we mentioned pneumothorax. Most babies might require some ventilator support. And then, of course, you have persistent pulmonary hypertension, which I'm going to explain in a little while. So just to go through quickly, they're usually for a baby that is delivered through meconium aspiration, meconium stain. Like if the baby is kicking and screaming and crying, there's nothing you can do. They have already swallowed the meconium. Where the meconium is, you can't reach. You can suction the ones in the mouth, but if it's in the lungs, there's no way a suction catheter is going to reach there. If a baby is not responding, you're going to do your basic technique. You're going to position the head, you're going to suction the nose and the mouth, and then stimulate the baby. If the baby is not responding, do not waste time in trying to suction meconium. That baby needs to be intubated, and you start positive pressure ventilation. You're not going to get the meconium from in the lungs. You need to give that baby oxygen as soon as possible, or you're just making the baby more and more hypoxic. Go ahead, Kevin. You have a question?
Doc, when you say, you hear me, Doc?
Yeah, hearing you.
Yeah, when
Go
you say
ahead,
stimulate the baby, you mean slap the baby?
You never ever slap a baby. I have to go teach you people neonatal resuscitation. You haven't had that lectures yet? But if you stimulate a baby, you just basically rub the back or you flick the heels. That is stimulation. Those old time days where the midwives hold you up and slap you on your butt and slap you all over no longer occurs. That is now child abuse. You're just going to rub the back or flick the heels. If the baby is not responding, then you stop and you intubate and start positive pressure ventilation. You understand that what we mean by stimulate?
Yes, Doc.
All right, so if the baby is not responding, then intubate and start positive pressure ventilation. I know the midwives still believe in slapping the babies, but it's not supposed to happen. It's actually considered, it's not even in the books anymore. So for most of these the babies that are severe, some can manage with just some bare oxygen. The severe ones need ventilation. The difference between RDS and meconium aspiration is that these babies' oxygen need to be at a higher level. And the reason you want to do that, it should be 95 and a little above to prevent pulmonary vasoconstriction, which is a major complication of meconium aspiration syndrome. So you want those vessels dilated. They are term babies. They're not going to have retinopathy or prematurity. Their organs are more developed, so their oxygen level needs to be higher. So it needs to be up to greater than 95 in order to prevent pulmonary vasoconstriction. And what you want to prevent is this complication that causes the death of these babies, is persistent pulmonary hypertension. Because the hypoxia in these babies can be so bad, is that the vessels become constricted and we cannot get them dilated. And so the treatment is a vasodilator if nothing else is working. We're ventilating, we cannot get the oxygen level up. They're sitting in the 70s, the 80s, despite our event on 100% oxygen. Then the drug to give is sildenafil is the drug of choice in Jamaica and milrinone. But it is not the primary. The treatment that is used internationally is actually inhaled nitric oxide. This is something that they give that goes directly into the lungs and cause vasodilatation. It's only a few centers have this drug. It's very expensive, but it works. It works. But the alternative we have in Jamaica is sildenafil and milrinone, which are vasodilators, and it can work as well. Might not work as well as inhaled nitric oxide, but those are the drugs that you need to use to get the pulmonary vasoconstriction under control and to get those vessels to dilate. We tend to use morphine. These big babies fight the machine like crazy. And the more they fight the machine, the more problem we have with oxygenating these babies. So most of these babies have to be sedated in order to get adequate oxygenation. And if all things fail, then there's what we call ECMO, which is not available in Jamaica, in which you just put the lungs at rest and just oxygenate the baby. But again, that's not available for pediatric patients. They have it for the adult patients at UA in ICU, but we don't have it for pediatric patients. The major complication of persistent pulmonary hypertension is that they can end up having chronic lung disease from the damage to the lungs. But the major one, the other one, is the risk of cerebral palsy. They have so much hypoxia, they can end up with poor neurodevelopmental outcome if they do survive.
Excuse me, Doc, can you please repeat the definition that you gave earlier for chronic lung disease?
Repeat that, please.
Can you please repeat the definition that you gave earlier for chronic lung disease in terms of the you gave an age?
Yes, I said any baby that requires oxygen or any form of ventilator support after 28 days, and this is baby, we're talking about the prem babies, they are considered to have chronic lung disease.
Thank you.
Okay. So even if they're on room air and if they still require CPAP, then these babies are considered to have chronic lung disease. Yes, Sabrina?
Yes, Doc, question. Did you say how we know that a baby with meconium aspiration syndrome has developed that persistent pulmonary hypertension? Or is it unknown
Yes.
separately once it hasn't been treated?
No, it's not. So if you find that your baby is persistently hypoxic and you do your blood gas and the PCO2, the baby actually looks blue because they're not oxygenating, the pulmonary vessels have not dilated. There's a formula that can be used to determine the amount, but this is at a higher level that they can calculate the amount of, in terms of the PCO2 ratio to determine if the patient has persistent pulmonary hypertension. But if you do your gas, the baby's oxygen is in the 60s, 70s. The baby is on 100% oxygen. That baby is in persistent pulmonary hypertension. Severely distressed, you cannot oxygenate your baby. Then that baby is in PPHN and needs. And so sometimes an echo can also show. You do the echocardiogram and they show that the baby's vessels are tight because sometimes they do it to make sure we're not dealing with a cyanotic congenital heart disease. So most babies that we tend to do, if we have the availability, echo is also done, and it can also show the pressure in the lungs in terms of the vessels and what is going on. But if you have a baby that has persistent hypoxia, severely distressed cyanose, that is persistent pulmonary hypertension. But ideally, you should actually get an echo to rule out a cyanotic heart disease. But most babies with cyanotic heart disease is not as distressed as a baby who has persistent pulmonary hypertension because their problem is not the lungs, their problem is the heart. So they might have mild respiratory distress, but not severe respiratory distress.
Okay, Doc, understood. Thank you.
Yeah. I have to go a little quicker. So just in terms of a pneumothorax, we mentioned it that it can occur in various conditions. If some persons can be too aggressive in terms of when they resuscitate. So if you're giving the baby too much, pumping that back too hard, usually have the valve that tell you when you're in the green, the yellow, and the red. If you're pumping so hard that you reach the yellow or the green, you can blow a pneumothorax. We mentioned meconium aspiration syndrome, RDS, and mechanical ventilation can always cause it. If you put up your peak inspiratory pressure too much, or even your peak and expiratory pressure, you can blow a pneumothorax if you don't monitor the babies carefully. So how can you tell that a baby has a pneumothorax? You guys are going to graduate soon. You're on the nursery, and they call you. How do you can you tell that a baby has developed a pneumothorax if the baby is on the ventilator? What do you look for? So the nurse called it, the baby is desatting, the baby looks blue. What do you look for to tell that this baby has a pneumothorax?
Do you listen for DGR respiratory exam?
Speak a little louder, please, Doc.
Did your respiratory exam? Do you like?
So what do you look for?
Well,
So what do you look for in the chest?
Well, absent breath sounds and affected cell.
Yeah, so there'll be decreased breath sounds. What else do you look for? Just by looking, what will tell you? When you look at the baby, what will you notice?
Paradoxical chest movement.
Yes, so one side of the chest is higher than the other.
Yeah.
Yeah, you said there's decreased breath sound.
Yeah,
What else?
Can you percuss with the affected side be louder?
Exactly. And if you palpate, what will also help you, especially if it's a tension pneumothorax?
palpate, you see tracheal tugging, or let me just announce it for now. So tracheal tugging and movement of the
Now,
heart.
let's start the trachea might be deviated, and the apex beat might be displaced. Those
Yeah,
are the
so
things
yeah,
that give you an idea that there's a pneumothorax, a severe pneumothorax. So you need to look for those things. And one of the things that our residents do is carry a flashlight. If the side that is have a massive pneumothorax or a massive pneumothorax, if shine a light there, it's going to light up like it's the night because it's pure air compared to lung tissue. So we always walk with our little flashlights to check both sides when a baby suddenly deteriorate and we're not sure what is happening. If one of the side that is hyperinflated and you put a light there and you see it coming from, you put it at the side and you see a big area that is lighted up, that's a pneumothorax. Or if you see it coming from the top of the chest and you put it at the side, that's a massive pneumothorax. So that can help as well to tell you if a baby has a pneumothorax. So most of what you said is correct. So sudden deterioration, as I mentioned, the apex is displaced, and this is an attention pneumothorax. Because you can have smaller leaks that are not tension, but the one that kills the baby is a tension pneumothorax. And this is a surgical emergency. If the trachea is displaced, the baby's apex beat is displaced, the vessels are now kinked, it's going to cause a problem. And the surgeons, they need to deflate that lung. And how do you do that? And of course, baby, we're grunting. So how do you try until the surgeons come?
Well, if it's will you go like between the just behind the anterior maxillary line and in front of the mid maxillary line, and you use like a needle, not a needle, the cannula to
Where do you put your needle?
say just behind the anterior maxillary line and just in front of the maxillary line.
There's a specific place. It's a second intercostal space, mid-clavicular line.
But I thought that changed.
Exactly.
No, I thought that changed for kids it's still second intercostal space.
Yes, you see, put it in second, or you can put it at the fourth in the anterior axillary line. But for most of us, we still use the second intercostal space. But the NRP, so you can put it at the fourth as well. So that's where the chest tube is going to be placed. But the surgeons don't like you messing up the chest tubes side.
Oh, okay, so just a second.
But you can put it at both places, you're correct. But we tend to put it in the second intercostal space, mid-clavicular line, and pull out as much air as we can until a tube is placed in the fourth intercostal space at the anterior axillary line. But both places are fine, as long as you get out as much air as possible. All right, so this is what a pneumothorax look like. This is a massive one. There's a tube already in there. That's a lung all collapse. Let me get the pen. So this is the lung all collapse here. That's the first line, and that's the second dot is where the fluid is. And then the third, somebody has already inserted a chest tube. So that's something you don't miss when you get an x-ray, because some people might see everything else but that chest tube there, which is a third dot, which is they're trying to drain the fluid from the air from the lungs. Everybody see that picture? And the different areas. So the first dot is a collapsed lung. The second dot, which I put at the bottom, is the air, which is all over. And the third dot, which is that little line there, is actually a chest tube. So we're going to go through this quickly now. These are easier. So neonatal pneumonia, as you remember, is not by the blood, it's transplacental. Whether the membranes are ruptured or not, babies get their infection mainly from the meconium, the amniotic fluid, sorry. So it's rarely that a baby gets an infection from blood. And it's considered, and they're more at risk when there's prolonged rupture of membranes, which is considered at 18 hours of life. So that's when they're at greatest risk. After that, to get in a neonatal pneumonia. The major cause worldwide is Group B strep, but most mothers now are getting prophylaxis. We don't have that in Jamaica as much as in other countries. So if they get the prophylaxis, if they're known to be Group B strep, I've had a child before that has had Group B strep, has a UTI that Group B strep or blood, then they tend to get prophylaxis at birth. We don't, for our mothers that has had that in the past, we tend to protect them, but now they're giving it in some countries to all mothers to prevent this, but that's one of the most common causes, and it has dropped in some countries. We don't have it as much as before either. But the other bug that you worry about is E. coli bugs, Klebsiella, Listeria, Group D strep can cause a congenital or neonatal pneumonia. Chlamydia can also cause a pneumonia, but it never occurs at birth. These babies might have an eye discharge, but presents 2 or 3 weeks later with respiratory distress and the x-rays in keeping with a pneumonia. So chlamydia tends to occur a little later. It doesn't occur immediately after birth compared to the other bacteria that can cause a neonatal pneumonia. It's non-specific. These babies can just present with mild respiratory distress. Most of them do present with mild respiratory distress, but then they can also have jaundice, abdominal distension, apnea. Babies just present different ways with various things, so you have to use your mind and try and figure out what is going on. And the chest x-rays is not specific either. It can present anyway, but you usually see signs of having atelectasis, signs of pneumonia in the different areas of the lungs. Just like so you would see in an older child, you see the signs of a pneumonia in a child that is distressed. We give them broad spectrum antibiotics to cover for both gram-positive and gram-negative. So we give penicillin and aminoglycoside is our first choice. And so we give Crispin and gentamicin for most of our babies who have a congenital pneumonia. If they go home and come back, then you have to consider community-acquired infection, so we might change up the antibiotics. Ampicillin, give something stronger, because we're not sure if it's a congenital or if it's something that is acquired from the community. So any baby that goes home and come back should not be started on Crispin. It's not, you have to consider other bugs. As I said, it's non-specific. They might just have patches just a little area there, a little area here. So it's very non-specific in terms of, it's like any other pneumonia that you see. This is a baby with severe pneumonia, in which you have a total whiteout, which is more seen in our prem babies. So the whole lung is just affected. And it's in keeping with classic GBS pneumonia. In a severe GBS pneumonia can actually look like RDS, or E. coli can do this, just damage the entire lung. So that's something you have to be aware of. That's the pneumonia. Any questions before we go to TTN, which I think is one of our last areas? So transient tachypnea of the newborn. I want to give one advice before I move on to this. If a baby comes with a congenital pneumonia, be very careful what you say to the father. You don't tell the father, if the father is there, even when you're speaking to the mother, you don't want her to feel bad. Don't tell her the baby get it from you. It's from the amniotic fluid, it's whatever. You can say, yes, the baby got the infection. It occurred from in utero. It's due to bacteria that was there. But you have to be careful, because some fathers might going to blame the mother for it happening. And sometimes mother has no control. Every female has bacteria in the vaginal tract. Sometimes it doesn't affect the baby, sometimes it does. So don't let the mother feel like she's responsible, or the father start to feel if it wasn't your fault why the baby is there, because we have had drama with that. So you have to be careful how you speak to the parents or how you tell the mommy what is happening, especially when the father is around. So when you go to, so that's just it about congenital pneumonias. So in terms of transient tachypnea of the newborn, this is a diagnosis of exclusion. Always remember that. It mainly occurs in mothers who have a C-section because the fluid in the lungs is not fully clear. They didn't go through the process of having to be born vaginally, the body being prepared to have this baby, the excess fluid being basically passing from the alveoli out before delivery, because cortisol and all those things helps to get rid of the amniotic, the fluid in the lungs. And they didn't get that. They were just delivered by C-section. So the body wasn't prepared for delivery. So they tend to come out with having a little, what we call transient tachypnea, the newborn. So they might have mild cyanosis, mild tachypnea. But as I mentioned, it's a diagnosis by exclusion. If a baby presents with respiratory distress after a C-section, if it persists, some books will tell you that it can last for 72 hours. Do not take that risk. If the baby after 48 hours is still tachypnic, you need to do a chest x-ray to rule out a congenital pneumonia. You have to look at other possibilities like a cyanotic heart disease or congenital heart disease if that tachypnea persists and the baby is not showing any signs of getting better. So if the baby, what we usually do at UE, if a has transient tachypnea, the newborn, after 48 hours, we might watch the baby. If the baby is not getting better or is worsening or is still tachypnic, we admit and we do a septic screen because it could also be an infection. And we do a chest x-ray. If the chest x-ray is not in keeping with a pneumonia, and then the baby, usually those babies start to improve after a day or two. We wait on the blood culture. If the blood culture is negative, so within 24 to 48 hours, that baby is returned to the mother. Usually distress resolved, and then we're more comfortable. But do not watch a baby for 1 to 2 days and suddenly baby crash on you saying it's TTN. Remember what I said, RDS, respiratory distress, not RDS, can present with various other conditions as a way of telling you that something else is wrong. So you need to look for that and do not watch a baby going on for how long and miss something like a heart disease or a pneumonia or an infection. So for the classic picture of what we call transient tachypnea, the newborn, which we rarely see, what they mention is that this is what you should not see in a baby who is, I don't know if I went put the pen there. I hope it doesn't block it. Do you see like there's a line going across that fissure? That is fluid in the fissure. You don't see that in normal x-rays. Are you seeing that line? In the lateral fissure? Yes, when you see an x-ray and you see that line, that is telling you there's excess fluid in the lungs. That's the sign that you actually see for a baby with TTN. That will give you a better idea that the baby has TTN. They also mention this classical thing about a wet silhouette. And basically what they're talking about, which again I rarely see, is these little intralobular, we don't even know if you can appreciate it. There's this intralobular fluid, as they call it, this wet silhouette against the heart, around the heart. And if you see in the signs where you have like a little shadow around the heart. So these areas where you just see like there's something surrounding the heart, but it's not actually in the alveoli, it's in between the spaces. And they call these a wet silhouette. It is rare. I'm not really telling you when you see it in a lot of x-rays. This is from a book, classic internet picture. I've rarely seen that. But the major thing, and you can actually see like the little fluid there, these little things that are around the heart, a little line there that is going. But that's what they call a wet silhouette. It's really rare. And that's what they can also see in a TTN. I'm going to finish up this with a quick thing in terms of surgical causes for respiratory distress that you should never miss. Pulmonary hyperplasia, in which a lung doesn't develop, can be unilateral or bilateral. If it is unilateral, the baby have a chance. If it's bilateral, the baby is going to die. You cannot replace lungs. It's not going to happen in a newborn. So there's nothing you can do for a baby with bilateral pulmonary hyperplasia where the lung don't develop. They need lungs to live. But if it's one lung and it is developed enough, then the chance is better for them to actually survive with pulmonary hyperplasia. It can occur with a congenital hernia, which we'll discuss. If the baby has oligohydramnios, it can be poor because if those babies are not able to swallow fluid, not able to get the lungs going, it's not going to occur in terms of the lung developing. Then you have rare conditions like skeletal and neuromuscular disease, where they just can't open the lungs to get fluid in and get the lungs to develop. So pulmonary hyperplasia, I want you to go to this first. Tell me which side you think is affected. Then we'll go back to that that slide. Which side has a pulmonary hyperplasia? I say 2 left, 2 right. Who is going to win? Who is going to give the 5th one? Any other guess? Well, just to disappoint the ones that it's not the right side. Which side is it? Which side is it have it? The right? Well, guess what, guys? You're correct. And why do you think the right side has a pulmonary hyperplasia? I want you to tell the others why you think it's the right side. No air entry. What else? What on the left side will tell you that it's not the left side that is affected?
Can see lung markings on the left.
And it's hyperinflated. It's compensating for the side that is not working. It is so super extended. And so everything, the heart and everything is pushed over to the right. The heart is not supposed to be on the right side. So this is pushing everything over. So that is a baby that has right-sided pulmonary hyperplasia. And if you look at the next film, how would it look on a CT? You see the area is so hyperinflated, and over here is where everything is pushed. There's no lung there. So that is a classical picture of pulmonary hyperplasia. So a radiopaque, so it's usually radiopaque that tells you that there's no air going into that lung. And so these babies, as I mentioned before, and of course, if you listen, the normal things that we say, they listen, there's no air entry, deviation of the trachea, all of that will tell you which side is affected. It's like when they have a massive pulmonary pneumothorax. And that is what, in terms of, just to give you an idea to when you look at the x-ray. So those babies, if you can save that one lung that is functioning, the chances is better than no lung. So that's pulmonary hyperplasia. You understand what a pulmonary hyperplasia is when you look at it and when you examine the patient. It's similar to a massive pneumothorax, but this is a congenital problem, is that the lungs just did not develop properly on the side that's affected. Now, when you come to a diaphragmatic hernia, this is a defect in the diaphragm. So what it does, and it occurs mainly on the left, is that the stomach, the bowel, sometimes the liver can go into that lung, and therefore it does not develop. So they do have pulmonary hyperplasia on that side, but it's not as severe as sometimes the congenital. It only occurs mainly on one side. And the major thing that should tell you it's a diaphragmatic hernia is a concave abdomen. If you see a baby that don't have a big belly, something is wrong. Everything, including the bladder, is in that baby's belly. And if you see a baby with a concave abdomen that is not a severe prem, where everything not develop so much and even them have a tummy, something is wrong. You need to, and that baby is in distress, the first thing you should think about is a diaphragmatic hernia. Sometimes it can trick you. I've seen it trick us a lot in terms of on the nurse where a baby presents and we're wondering, it takes us a little time to pick it up, but eventually we've tried to figure out what is happening. But it's something that you shouldn't miss in terms of, because if it's just a mild one, you might not be able to see it that well. But for the severe ones, you should pick up that there's bowel inside the chest wall, which is a classical picture. You see the bowel loops, stomach, everything is in there. And you see that you pass an NG tube, and the NG tube is in the chest. So that's why any baby with distress, you should always pass an NG tube before you do that x-ray, so that you don't miss out congenital abnormalities. We tell the nurses that all the time, but sometimes it doesn't happen. But it can point you to a congenital chest deformity, a congenital malformation. The last thing I look at is a tracheoesophageal fistula. I'm actually going to show you a diagram to tell it in the interest of time, which is the more common. So the diaphragms, in terms of the congenital malformation, the most common one is when you have the upper airway that is just like in the form of a bulb, and then the low attachment at the bottom. This is a tracheoesophageal fistula, which is esophageal atresia, and then the distal part attaching to the lung. So that's the most common cause of a tracheoesophageal fistula. The others are less common, so we don't worry about that. This one, in terms of when you have just a slight attachment, is rare, but it tends to appear. Let me show you the one that, so this is the most common, as you see on the diagram. So that's the one we see the most. The ones that the one that tends to present later on in life, if you have a newborn that is having recurrent, or a child who is 1 or 2 years old who's having recurrent wheezing, recurrent pneumonia, and it's not adding up, look for this one, where you just have a H-type fistula. It's very rare, but it's something you have to consider in a child that is just, it keeps on coming to you with a recurrent pneumonia. The child is well, otherwise what could be causing this? You have to look for other things if the child is not immunocompromised. The others, again, is also rare. So the esophageal atresia with the distal fistula is the most common one, and this is what the diagram would look at in terms of the presentation. So you try to pass the NG tube, it's curling up in the esophageal, in the upper part of the esophagus. Or you might see the tip here, and that's why you must always try to do that x-ray. That's how it normally presents in terms of a tracheoesophageal fistula. So how these baby present, and we picked the last one I had was a nurses on the labor ward that called us about this baby. What they noticed was that the baby was having excessive salivation. So you find that these babies, just after delivery, they have to be suctioning, and that baby had a classic esophagus because the baby is producing saliva, but it's building up in the pouch, and so the pouch keeps on the baby is just passing it back out because it cannot be swallowed. If the baby is choking, coughing, vomiting, having episodes of cyanosis, and usually these things is picked up when you try to feed. That's one of the ways you know something is wrong. You're trying to feed the baby, but every time you try to feed, because the food has nowhere to go, it's going to come back up and cause the baby to start choking or vomiting and suddenly get blue. You should consider esophageal atresia with a distal fistula. Again, this is surgical and it can be confirmed by passing an NG tube. And of course, it's a surgical issue, and it should be referred to the surgeons who will take the baby to theater and try and do some correction. So that's a major thing about the surgical things that you must try not to miss. And as I mentioned before, choanal atresia as well. Those things can occur, so be aware of it. Are there any questions?
Doctor, I have a question.
Go ahead.
Previously where you spoke about the premature babies and giving them surfactant, is it possible to give them steroids instead?
No, the steroids that you give is in babies with, I shouldn't have said, so they used to give the steroids early to prevent chronic lung disease. They try to prevent chronic lung disease, but studies have shown that for some babies it has resulted in bleeds. Oh, somebody mentioned the CVS session is at 2 o'clock and it's on the ward. So, but we talk about that at the end almost. So most persons have moved away from that, and they tend to give steroids later on if the baby is on the vent and we cannot get the baby off. Steroids have been found to help sometimes in the severity of the chronic lung disease. But they have moved away from giving steroids early because it has been associated with a lot of complications. Because that used to be the practice. When I did neonatology years back, they used to do that, but most of the literature has found that it has complications because it can lead to steroids on the brain don't work so good. It increased the risk of cerebral palsy, pulmonary hemorrhage, and a lot of other complications. But that's not the first choice for RDS. The first choice is always surfactant. Steroids is not going to help because remember the steroids help with the maturation of the type 2 pneumocytes. You can't wait on them to mature in a baby who is severely distressed. And you need to give the surfactant just to open up those alveoli. It's going to take a while before those alveoli is going to mature when you give them the surfactant artificially. I mean the steroids artificially, because it takes a certain amount of time for the steroids to work to get the type 2 cells. So that's why it's not the best option.
Okay, Doc, understood. Thank you.
Any other question? I know you guys, the low birth weight thing is a short lecture. It's around 20 minutes. I don't know if you have the time to just do it so you don't have to come back.
Doc, we actually have a session now.
Huh?
We actually have a session now with Dr. Thomas, I believe.
Oh, so you have to come back for that one. If anything, I'll just send the slides to you to see. Or you guys can tell me when you're next available. Will you know at this time when you're, because it's, as I say, it's a half an hour lecture. It's not going to take long. But you need to let me know when you're available.
Next week, Tuesday morning, I don't see any lectures scheduled.
All right, so we'll try to do it at that time then. Next week, Tuesday at 9 o'clock. Everyone agree to that time? Yes, no, I need to know.
Doc, that's fine with me. Once Dr. Bailey does not have anything else planned, that should be fine.
Oh,
Dr.
so
Bailey
next week,
actually suggested that for you.
I think that will be fine. That's August, I'm on service then, so I'll have to do it early. Low birth weight is at 9 o'clock. All right, I'll put it for 9 and we do, as I say, it's not a long lecture. So we should be able to do it within half an hour. All right, so that's the time we're going to put down my phone for that's the time we're going to do it. All right then. Okay, class, sorry about the whole disruption this morning. All right, I'll see some
No
of you
problem,
later
Doc.
in the next section.